psychiatry, and quite literally on a daily basis, is when a decision has to be made to hospitalize your child for psychiatric reasons. How does that work? Is it because of your side of recommending to them? Is it the family just kind of giving up? There's so many complex issues associated with this. Um, I'm sure there's a lot to say. In fact, so much so that if y'all who are watching see a QR code on the top of the screen there, it says hospitalization. Dr. Patino wrote a book about this exact subject. So let's dive into it, Dr. Patino. Tell us more about this.
Well, let me say that the book is kind of a guide for parents in terms of the process, both of getting your kid into a hospital, what happens in the hospital, how to process, how to communicate, and kind of some ideas on how to deal with the feeling. And let's start with the idea that putting your child in a psychiatric hospital is a terribly confusing, scary experience for most parents, right? Now, understanding that most parents hospitalize their kids in a state like Arizona, kids cannot hospitalize themselves. So it becomes a responsibility of the parent or guardian, sometimes the state is the guardian, that has to approve the hospitalization. So that becomes a very important factor because we have to understand that parents have a lot more power and control. Guardians have a lot more power and control into the process of hospitalization than they know or they believe. And actually, it's very easy to intimidate the parents into hospitalizing a child. And it happens a lot. We're not going to dive too much into that, but sometimes parents are kind of reluctantly signing their kids in the hospital. And I do have to say, if a parent doesn't want to hospitalize a child, okay, exists the possibility that Child Protective Services will be called. However, most of the time, in my experience, Child Protective Services is not going to force the issue unless they feel that the child has no other services available or the child is in imminent danger, right?
Let me
So,
let me ask you a question there.
yeah.
Let me just stop you right there. So CPS can get involved, and the police, I assume, can also get involved. Can they force that, or is it simply to? It has to be done by the parents, so they can pressure the parents to do that, or can they be hospitalized by law enforcement or by CPS?
Unfortunately, the parents are told often in the emergency room, let's say the child shows up in the emergency room because they had a suicide attempt. They took an overdose of Tylenol, right? And the kid was feeling depressed and suicidal. They do their assessment, they do the medical rescuing part of the emergency treatment. And then usually a social worker or a psychologist will come and see the kid in the emergency room and will recommend hospitalization.
Hmm.
We have to be very clear that there's there's a lot of importance on the wording, right? When we say recommend hospital, can you hear me? Are you there? It looks like your connection is kind of low. Can you hear me? There you are. Much better now. Can you hear me now?
There we go.
Yeah. So what I was telling you is that during the emergency room visit, a social worker or a psychologist will see the kid and recommend hospitalization. That is a recommendation, not a mandate. Neither the social worker or the emergency room physician or the um, police have the authority to take that child. The only person that has the authority to force the hospitalization is Child Protective Services. Now, the problem is that often the psychologist, the social worker, the emergency room physician, they will say things like, well, if you don't hospitalize your child, I'm going to call Child Protective Services, they're going to take your child away, right? And that is not a correct way of doing it. You have to tell the parents that if that you are recommending hospitalization and that you recommend that is done voluntarily. If the parents refuse, then you have a responsibility if you believe the child is in danger to call Child Protective Services and have them come over and take a look at the kid, right? But we should never threaten parents. with hospitalization. That happens too often, right? And I train students and I always tell them, don't do that. You know, you have a responsibility legally if you believe that a child is in danger or is being neglected or abused, you have to notify DCS whether it's suicidal or not. But we should not be using that as leverage for the parents to succumb to the pressure, right? Because the parents have to do an informed consent. And informed consent should not be a threat, right? So that is important.
So, from a legal standpoint, it seems like it would be pretty important for the parents to be on that. But I do know, you and I know of a person, actually. I think you treated their daughter, a good friend of mine, who every time he's had to hospitalize her, it's been just an incredible ordeal. Very difficult for the child, very difficult for the family. Child always blaming them, saying that that she's being forced or incarcerated. Is that common?
Absolutely. You see, you have to understand that we're dealing with an age group, 12 to 18, of people who are in the process developmentally toward independence, right? So any authority or restraint is going to create resistance, right? So fortunately, the parents still have the power to force things if they choose to do so, right? I mean, legally and ethically and morally. Now, what is important to understand too is that the experience for the child is a difficult one, right? Because it's a very helpless position on a child who's starting to believe that they're in control of their lives, suddenly realizing that they're not, right? That there are authorities outside of them that can force them into doing things. That ends in the United States when you turn 18 years of age, right? When you become your own guardian. But before that, parents have tremendous amounts of authority and tremendous amounts of responsibility. Right?
So if you were, I'm sure it's in the book, but just for our viewers, if you were to list, is there a way to do that? To list, hey, here are the top five things that say, hey, you know what? It's time to pull this, right? It's time to get your child into a hospital.
What I always recommend is that usually the hospitalization process is not going to be fully directed by the parents. Usually the child is going to be taken to an emergency room, to a crisis center, to a psychiatric evaluation center, where somebody's going to do an assessment. And the most common reasons for hospitalization, by far number one, is suicide attempts, right? So if you have a child who's expressing thoughts of harming themselves, thoughts of dying, feeling so bad that they think life isn't worth living, that kid requires an assessment, whether it's done in the medical emergency room, in a psychiatric center, in a therapist's office, in a psychiatrist's office, or in the admission center of a hospital. The first thing that the parents need to think about is I need to have my kid evaluated. I mean, in Arizona, here in the Maricopa County, we have crisis teams that may show up at your house because the kid is refusing any treatment, and the police was called. The police calls a crisis team, and they come and evaluate the child, right? So, suicidal thoughts or behavior become by far the most common reason we hospitalize children. In the hospital that I direct, we have 59 adolescent beds for acute care, and we have 64 adolescent beds for residential care. In the acute care, I would say that two-thirds of the patients are there because of suicidal ideation.
Mm.
There's another level which is not suicide ideation but is self-harm, and this is very common nowadays. Kids that cut themselves as a way of coping with their emotions, learn behaviors, burning themselves. Some of those kids, if the behavior is very pervasive and intense and frequent, we recommend they get, not that they get hospitalized, that they get assessed, right? They probably another very frequent cause for hospitalization is psychosis, meaning being out of control with reality, experiencing paranoia, persecutory delusions, seeing things, hearing things that are not being caused by the use of drugs, right? So we'd like to separate psychosis that is the result of an intoxication from drugs and the one that is the result of an illness. Then we have, go ahead.
No, I was
Then we
please.
have Probably the next two are going to be severe mood disorders like bipolar disorder, depression, and then we have substance abuse. And nowadays, probably the abuse of fentanyl has become very prevalent. So we tend to detoxify a lot of kids from fentanyl if they survive the abuse.
So once the child's in there, and obviously those are very extreme things to occur. This is not just, hey, they're not feeling good, smoked a couple joints. These are serious on the drug side, and of course psychosis, and in depression and suicidal ideation. What though afterwards? Get the child in, checked in, get them stabilized, get them some help. What are the challenges that these parents and these kids face after being hospitalized?
Well, you see, part of the hospitalization process involves a series of events. You have to think of it as the patient going to a series of assessments, evaluations, determination of needs, and what will be the least restrictive environment that will benefit that child for the specific problem of the child. We call that individualized treatment, right? Now, the hospital is a artificial environment. It's not a natural environment, but it's very structured. So one of the benefits of being in a hospital is that you have structure, right? A structure that is predetermined. I mean, from the time you get up in the morning to the time you go for meals, from the time you go to groups, from the time you go to a family therapy session, from you meet with your social worker for discharge planning, all of that is predetermined. Okay, so you're removing choice from the kids a lot. Then you have a whole series of assessments. You have psychiatric assessments, medical assessments, and then we have to initiate a treatment, right? A treatment is to stabilize the condition that brought the patient in and start developing guidance for what is going to be the best treatment after the hospital. Uh, another of the benefits of the hospital is that you have support, right? Non-judgmental support. So one of the things that happens between kids and parents, especially with adolescents, is that the adolescents grow up in some cases very comfortable being abusive with their parents, right? So they feel very comfortable expressing all the negativity to the parents, and there's reasons for that. In the hospital, they don't receive judgment for that behavior, right?
Mm.
So it becomes a little easier for them to start ventilating and start developing certain skills into the how to. I mean, you also have peers, and there's peer pressure and interactions that can be positive, but it can also be negative, right? So you have to kind of keep those things in place. One of the things that we start from the beginning of the hospitalization is a process we call discharge planning. Discharge planning means what are the safest processes that can be put in place for this kid to receive the best chance of rehabilitation. And there are different levels. I mean, there are patients who have been hospitalized 5 times. They refuse treatment on the outpatient basis. They're physically violent toward themselves and others, or they're chronically psychotic with limited compliance with medication. So we may refer them to a residential program, right? There are kids that are in between that they go to a group home. We have kids, and most kids will go home, right? But if they go home, we have to develop services around the home so the parents can utilize those services. For example, individual therapy, family therapy, intensive outpatient services, substance abuse treatment, and rehabilitation. So, depending on the diagnosis, the maturity, and the culture of the child, we're going to try to accommodate those things.
So this is just obviously a blip in getting hold of the child, taking care of a specific crisis, if we will, getting them stabilized. But what does it look like for the long term care and the long term ramifications? I mean, for the parents, obviously they get a little bit of a break if they can't control the child, but also there's huge costs involved. And for the child, there's some, so I would assume there's some social ramifications. The fact that they've been hospitalized, I know, affects certain rights down the road. How does that all play out typically?
Well, it doesn't. It depends on the state. It doesn't really affect your rights because it's totally confidential. It's different than juvenile criminal services, right? But in terms of psychiatric services, only if the parents allow the records to be released, they can be released. So from that perspective, what happens is that there are consequences of being hospitalized, right? There's a stigma associated with this. Is there's self-esteem issues in terms of, I mean, I got so bad that I ended up in this place. What's wrong with me? Type of situation. There is a lot of um, shame from the kids. There is the potential for violence in the hospital, right? Because some of the kids maybe have evolved culturally and psychologically to abuse other kids, right?
Mhm.
So there's a lot of things that we have to be very vigilant for in terms of trying to minimize those behaviors. I have to tell you, we're not 100% successful at that, but we try to be in the 95% if we can, right? So we have a lot of staff monitoring and things of that sort. And that's part of the whole assessment. So part of the problem is that at the time of the patient being released, especially when they go home, there's a lot of insecurity in part of the parents, right? In terms of how do I go about handling this, right? And something that happens often is that parents start walking on eggshells around the kid, and the kids start feeling that you're walking on eggshells around them, and then the communication starts becoming very logical but very superficial. Okay, and at the end of the day, it becomes a process of regaining trust, bi-directional trust, meaning that the parents trust the kid and the kid trusts the parents. And that's a process, it's not an event. But I always like to present hospitalization in the psychiatric hospital of today no different than going to an ICU because you had a heart attack. Right?
Mhm.
Uh, if you go to a hospital and let's say your wife has a heart attack and she's in the ICU, you really want the doctor to tell you that your wife is not going to have another one, right? So the same thing happens in the psychiatric hospital. Parents want some reassurance that the kid's not going to attempt suicide. And things like a heart attack or a diabetic coma or a suicide attempt are not just events, there are risks, right? We in psychiatry, we're terrible at predicting future behavior, but we're very good at predicting risk, right? So if you're in the ICU because you're in a diabetic coma and your sugar was 600 and you gain a lot of weight and you don't exercise, you drink alcohol excessively, and you ask the ICU doctor, is my dad going to have another diabetic coma? The doctor is probably going to tell you, I don't know, but I can tell you that if he continues with those patterns, right, is likely to have another coma. So what he's telling you is that the risk is high. So it is our responsibility to help the parents understand how to decrease the risk, right? So how do we decrease the risk of potential suicidality? So we do it by providing psychiatric treatment, psychiatric medications, psychotherapy, family therapy, all the things that need to happen to decrease the intensity of that environment so the kid has and the ability to rehabilitate and become more adaptive into their environment. And that's important because our job is not to fix the kid. Our job is to facilitate the kid continue with their development in an adaptive, healthy way, right? Now you need to understand most adolescents will never put their bodies inside of a psychiatric hospital. Being hospitalized psychiatrically for an adolescent is an exception, it's not a rule, right? Most kids that have substance abuse problems will never be in a psychiatric hospital, right? Most kids who are depressed are not going to be in a psychiatric hospital. Most kids with anxiety disorder and panic are not going to be in a psychiatric hospital. But there are ways to identify who's at risk. People who have sustained significant neglect and abuse as children, people that have a strong family history of psychiatric disorder of any kind, right? Kids who have attention deficit disorder tend to be more disruptive and aggressive. Kids that have certain types of autism may end up in the hospital more often than others. So we have to pay attention to the kids' growth and their behaviors, right? I mean, adolescence should not be the time for us to start paying attention to the kids.
Mm.
You start paying attention to the kids when they're born, okay? And you recognize that it is your responsibility to facilitate balanced growth, right? If you want to establish rules and respect and communication when they're 15 years old and you never did it before, it's going to be very difficult.
Seems a
Okay?
bit too late.
Well, it's never late, right? I mean, I've been doing this for 34, 35 years, and I have to tell you, I've been surprised many times by kids that I would say, God, these kids will not stand a chance, and they're very successful people. So I always tell parents and kids, prove me wrong, right? Prove that what I'm thinking of you 5 years down the road is something that you have power to change, right? But you have to work in a way that you're providing the structure, the therapy, the support. You need to. You We're facilitators. I mean, very often in the hospital, I get into this situation in which parents are very focused on diagnosis, right? Actually, my students get terribly focused on diagnosis. What is my kid's diagnosis?
Mm.
And I said, well, number one, diagnosis in psychiatry in that age group is always a work in progress. And diagnosis in psychiatry is about movies, not pictures. Because they have this idea that if you have a diagnosis, you have an answer for that diagnosis. And I'm not talking about diagnosis, I'm talking about a kid's life, right? I'm talking about adaptiveness. I'm talking about the ability to be content with themselves and to function in a very demanding society, right? So we can look at this in terms of intensity and frequency and how do we decrease the intensity or frequency or whatever they have so they can live. My adult patients make fun of this, but I always say I just want you to be as miserable as the rest of us, right? Because you're more miserable now. So let's make you balance. I mean, it sounds paradoxical, but the reality is that everything in medicine, I would say 99% of medicine is about how much, how often, and how does it affect your functioning. And reducing the how much and the how often should translate into the patient functioning better.
Mm.
That is it. I don't care if it's diabetes, hypertension, cancer, whatever it is not about controlling the illness, it's about facilitating rehabilitation.
And of course, hospitalization is just one aspect of it. If a crisis does pop up, doctor, once again, thank you very much for your wisdom. For everybody out there interested in learning more, go ahead and click on that QR code. It'll take you to a place where you can purchase the book. And hopefully, we'll see you all again next week.
Hey,
Take
thank
care.
you.